We can do that with all sorts of dentistry. We can do that with implants, we can do that with full dentures. So here's a case of a lady with typical dentures, NHS dentures. This is her view initially. She didn't like the fact that her dentures looked very, very false. We corrected the dentures initially and we increased her OVD again by 5 millimeters to give her an increase in facial appearance. We tried those new dentures in place, and of course this is just the wax trying at the moment to try to get a feel for what the patient looked like, whether the patient liked them. Patient was comfortable with the more ragged natural appearance. And if we go and look at the facial appearance that we've corrected, which is a milled bar, a square-shaped bar, that then allowed us to make a horseshoe upper denture with those anterior teeth, those upper anterior teeth, far forwards, 2 to 3 millimeters forwards of where they would be normally on the ridge. And that gave the patient that better lip position and allowed the patient to have not only a well-fitting denture held on by the implants, but a decent restoration and improved facial aesthetics as we go from original through to try-in to final definitive restoration. This can be done typically with large restorative case. Let's look at this lady. The first thing again we notice with this lady, facially she doesn't look particularly happy. Facially she's very square in the face. She's overclosed. She's got a slightly fattened face. This is her now with a piece of wax in place. So all we're doing is we're testing the new vertical, testing it with this typical horseshoe piece of wax, 5-6 millimeters thick. We can add more on and increase vertical more. We can take more off, ask her just to squeeze a little bit together. And it's really important that you give her a mirror and she can have a look in the mirror at what she looks like. Also a mirror at the side, she can see at the side what she looks like. Very important that she brings somebody with her who can also help her in achieving what she feels is the correct aesthetics. So from there to here, from being overclosed to increasing that vertical facial height. If we look now in side view, again we've got that class 3 style of facial profile and increasing about 5 to 6 millimeters. Again we now go into that class 1. So improve it in profile from the back. Yep. I've got the 5-minute warning sign, guys. And we'll be there, we're nearly there. So in facial profile, she's improved. We now look at a dentition, a typical very, very worn dentition, lower teeth starting to splay, loss of posterior teeth, so she's posturing forwards, losing vertical dimension again. And we don't need to go into the hows and wherefores, again that is the carpentry. We prep the teeth, we take some lower teeth out. We give her some upper crown and bridge work, lower crown and bridge work, and again we've now done our reconstruction, increased the vertical, given the 5 principles of occlusion, and facially that's had an impact in our patient. Interdisciplinary treatment, same thing here. Lady wants a new smile for her 60th birthday, teeth very badly worn. We go to our wax and we start to work with the wax squash bite to see how much we're going to increase vertical dimension by. And straight away, as we increase her, the tone in the face gets better. We stretch the face a little bit. We start to do our photography, diagnostic waxing. She's going to have periodontal surgery because she's also got a very gummy smile. We now get into our tooth preparations. And we fit her with, again, some crown and bridge work, upper and lowers. And the most important thing, again, we've increased the vertical dimension. We've improved facial aesthetics. Final case, and the one where we want to just change this ever so slightly and think about when we decrease. Okay, when would we decrease vertical dimension? You could decrease vertical dimension if you had somebody who had a very, very long, thin face. You wanted to make a facial impact and close her down. And very often we also decrease vertical if we want to get our anterior teeth closer together so that we can recreate anterior tooth contact. So here's a lady who fits into that position. We look at her initially. This is her intercuspal position. We ask her to close her teeth together, and you can see she's more or less edge to edge. She's suffering from temporomandibular joint problems. She's got clicking in her joints, headaches. She's had these for 15, 20 years. Had a lot of restorative dentistry done over the years, and she also wants an improvement. So we go and mount our study casts. A round retruded axis position. Straight away as we mount the study cast, we can see we've got a slide, and as the models are mounted round retruded, we now develop some space anteriorly. I've Pindexed the model so I can take out the posterior uppers and lowers, which will give me a true reflection of what the anterior tooth relationships are going to be like if and when I've eliminated that slide. I've done an occlusal adjustment. This is my anterior tooth relationships after the occlusal adjustment. We do further adjustment on the models. This is now my anterior tooth relationships once I've done occlusal adjustment at the back of the mouth and at the front of the mouth. I've reduced vertical dimension by approximately 5 millimeters. But that 5 millimeters have now given her overbite and overjet and the startings of anterior guidance on her anterior teeth. Absolutely essential in order to protect your posterior restorations and to get rid of her TMD. Now it's a simple job of prepping the upper anterior teeth, dentine bonding, immediate dentine sealing, putting the prototypes in place, and then the definitive EMAX restorations. And when we look at the case now, because we've reduced vertical dimension, what was an edge-to-edge occlusion and temporomandibular joint problems is now a class 1 occlusion, albeit the incisors aren't hitting in the cingulum, so we've got a reduced overbite and overjet, but at least we've got some. So when she starts to do her normal bruxing pattern, she's bruxing on her anterior teeth, which again is class 3 leverage, not class 2 leverage. We started like here with the smile, and we finished here with the smile. At the end of treatment, she'll also have an occlusal splint. So we've got a patient where we've created good aesthetics, we've eliminated her temporomandibular joint problems, we've given her the 5 principles of occlusion, and we've also changed her vertical dimension for the better. Thank you very much for your time, and I hope it's been of some use. Thank you.
Thank you, Professor Polly Tipton. দর্শক আপনাদের যদি কোনো প্রশ্ন থাকে তার কাছে আপনারা করতে পারেন।
Fantastic presentation actually I have ever heard in my life.
Thank you.
Actually, really, I'm really pleased to know that if somebody wants to be young, he needs to. I also want to be young.
Younger.
Young, yes. I want to be younger. 5 years, yeah.
5 years.
Yes, thank you. So actually, there should have so many questions, but actually we are just running short of time.
If anybody wants to ask any questions, you can see me during the conference. I'm very happy to answer any questions.
Okay, so if anybody has some question or any problem to solve, you can talk to him. So thank you all, and thank you, Dr. Punan.
Sir, it is already time is up, sir. I have one question regarding clinical point of view. After Salah? Okay, personally I can. Okay, thank you very much, sir.
While providing additional performance benefits such as no mucosa irritation, it also comes visible irritation of users. A unique flavor also added in this toothpaste. After extensive research by VMF of France, they have developed a new flavor of Mediplus toothpaste. That is the spearmint and peppermint. What are the benefits of brushing with Mediplus fluoride gel? It rapidly relieves dental hypersensitivity, helps to prevent cavity, prevents gingivitis, helps teeth stay white, shiny, and bright. It has only one pack popular size, that is 100 gram. Thank you.
The product, the laboratory ingredients, আর সবচেয়ে বড় যে কথাটা হচ্ছে বাদি আমরা প্যাট্রোনাইজ করছি মেডিপ্লাসকে শুধু টাকার বিনিময়ে বা আমাদের খাওয়াচ্ছে পড়াচ্ছে তার জন্য না, আমরা ল্যাবরেটরি টেস্টটা দেখে আমাদের এক্সপার্টের মাধ্যমে যখন দেখেছি এই টুথপেস্টটি সত্যিকার অর্থেই আমাদের জনগণের জন্য, আমাদের মাড়ির জন্য, সুস্থতার জন্য, ওরাল হাইজিনের জন্য ভালো। আমি আজকের এই অনুষ্ঠানের আয়োজনের পিছনে এবং মেডিপ্লাস জনগণের সেবায় নিয়োজিত এই ব্রত নেওয়াতে বাদির পক্ষ থেকে মেডিপ্লাসকে একটি ছোট্ট উপহার দেওয়া হচ্ছে। এনসি সরকার, নারায়ণচন্দ্র সরকার বাদির পক্ষ থেকে এই সম্মানসূচক কেসটি গ্রহণ করলেন। ধন্যবাদ। বিগ হ্যান্ডস ফর দ্য Mediplus.
A dentist from Bangladesh who had the opportunity to get clinical training in endodontic for long 4 years in Russia. And in this country, he introduced this system of root canal therapy. And I think at the moment there is no private clinic or there is no hospital which is not running endodontic treatment there. Now Professor Samsu Alam, he is the immediate past dean of the Faculty of Dentistry, BSMMU, and he is the chairman of the Conservative Dentistry of the Dental Faculty, BSMMU. So, please, Professor Dr. Samsu Alam, I request him for his presentation. Thank you.
Thank you. Chairman of the session, Professor Kazi Mehedul Alam, my respected teacher, ladies and gentlemen. Sorry.
Hello, check. Hello, microphone testing.
About the root canal therapy, that is, nowadays in Bangladesh and all over the world, the root canal treatment is very much popular. And in our daily practice, in our institute, and in our clinic, daily we are doing the root canal treatment. Actually, the root canal treatment in our country, maximum of the dental surgeon is doing conventionally. And some of us, we are trying to overcome this and we are practicing with the rotary system. We are using the rotary system. But the percentage is very few. But in rotary system also, there are many instruments are required for the cleaning and shaving of the root canal system. But now, recently, পেছনে শোনা যায়? Yes, you can ask a question after finishing my lecture, no problem. My first question is why we do clean and shave the root canal system. My topics is cleaning and shaving of the root canal system. The main objective of the root canal is to save the tooth at its functioning state, to back it into the functional state. To make the functioning of the tooth, what we have to do? First thing is to eliminate the bacteria and their metabolic byproduct from the root canal system. The root canal system is so notorious. Many bacteria are present inside the canal, especially the necrous tissue and infected tissue. And this bacteria, the main objective is to remove the bacteria. That is, we have to make an bacteria-free environment inside the root canal. And another objective is to prevent the re-entry of bacteria into the root canal system. This is the two objectives. Now for this, we need, if you want to do properly clean and shape the root canal system, you must have a good access cavity. How we'll do it? Just a short video, you can see it. For the premolar and the molar, use the number 4 round bar. Or 6, you can use, if the surface of the tooth is very big, then you can use the number 6. Otherwise, number 4 or 6 you can use. But for the anterior teeth, what bar you will use? You will use the number 2 bar, especially for the small canal or fine canal. And for access cavity preparation, there are many instruments now available. Regarding this, now Dentistry has introduced 3 gates together in one instrument. Then after using that instrument, you can refine the access cavity and you can clean it properly. Thus, you are cleaning it with the special instrument and irrigating it with sodium hypochlorite. And 5.25% sodium hypochlorite is recommended for cleaning of the total root canal system. And you can use even 1% or 1 to 5.25% is the action is almost same, but the maximum author preferred the 5.25%. And during access cavity preparation, you should not cut the wall and you should not touch the floor of the pulp chamber. Now we are looking at canal orifice. If you can do the straight line access, maintaining the standard protocol, then what will be the result? Just next slide you see. The accessibility will be like this. A straight line access. This is the prerequisite for cleaning and shaping with the rotary instrument. What we do actually? This picture you show, there is some angle in the, that is you have not removed here, wall. And here is the bulge of the cavity. And there is chance if this happened, what will happen in the next during the preparation of the root canal? There is every chance of fracture of the instrument. And you cannot clean properly it. And ultimately what will be the result? You cannot remove the bacteria entirely from the root canal system. After correction, before this and after correction, it will be like this. Now, there's another point. This zone is called the apical control zone. If you maintain this zone properly, then you can easily make the bacteria-free environment. And you will have to, during irrigation, during preparation, you will have to remember this. This apical portion is very critical, very, very critical. Here the apical delta is present, accessory canal is present there, and you will have to clean it very properly. Instrumentation is very difficult here. If there is some curvature, you will have to remember it. In each and every file, you should have to bend before insertion into the root canal system. And this portion, that is here, cement-enamel junction and the apical foramen, that is the distance from the cement-enamel junction and the apical foramen. If we want to do root canal with the conventional method, that is, if you want to use the hand instrument, then you must create apical stop here. That is, this is the diameter, your last slide you have seen. Here you will have to block it with the dentin chipping materials or artificial materials, you will have to stop it. Otherwise, there is every chance of introducing the irrigation solution or contents of the root canal system into the periapical tissue. And that will be very dangerous and it will give you the flare-up. These are the system now all over the world. Endodontics are using, these sorts of instruments are using. Especially in our country, we are also using 2 or 3 systems here. And I am practicing with this green color shown here. This I am using the Pathfile, ProGlide, FlexMaster previously I used. But many instruments are needed, many instruments. Protaper next, M2, Wave 1, Sabron Endo and Colton Endo also. Now in Bangladesh it is available. You can use easily. But most of them, if you want to do it using this instrument, you require many instruments. Minimum 3 instruments you need. But my topic is single file technique. With using the single file, only one file is needed for preparation of the total root canal system. That is called the Wave 1 system. You can use it. And I'm practicing with, and it is very friendly, you can use. But I think it is a bit expensive than that of Colton or Sabron or the Protaper system. This file you cannot use, reuse the file. The one time, only one file is required for only one canal. If you want to prepare the molar teeth, if it has 3 or 4 canals, then you must use the 3 or 4 instrument. And another disadvantage is that the Wave 1 motor, you can use the Wave 1 file only. Now, you can use the Wave 1 as well as the continuous motion file. Then all the files can run into the Wave 1 machine. But the Wave 1 file, you cannot use in the other system. This is the difficulties. The manufacturer made them like that. This is the Protaper system. In Bangladesh now it is, I think it is popular. Here also many instruments is required. That is shaping file, 3 shaping file and 5 finishing file. That is F1, F2, F3, F4 and F5. Previously it was 3 file, now it is for anterior teeth, now it is 5 file are required for the total finishing of the canal. And for shaping, you must use at least 2 or 3. In my clinic, I have prepared and sealed this using the Protaper system. It looked like very difficult, but actually it is not difficult. If you practice, I think few days is required for using this instrument. Sabron Endo is also very friendly, and today most probably our friend from India, he will tell about the Sabron Endo and other things, yes? Tomorrow, and it is very friendly and very useful and you will get fantastic result from the Sabron Endo also. Here also, K3 accept file, here also needed at least 5 file need. And another latest Sabron Endo version is this canal is prepared with the Sabron Endo. And this is another TF, that is twisted file from Sabron Endo. It is also very good. I tried and I have done many cases with using this twisted file. And here they have divided into 2 groups, that is anterior teeth and posterior teeth. Just step 1, 2 and 3. 3 file is required for the total preparation of the canal. Very easy, very easy. This canal is prepared using twisted file. This is the high-plex CM. And it is very flexible file. Even in 80 degree, 90 degree curvature, you can use this file. Very friendly, and there is no chance of breakage of the instrument. Very good. But here many instrument is required. They have divided into the small canal, medium canal, and the large canal. And in every canal, you must use the minimum 5 files or 6 files. It is also available in Bangladesh. You can use, you can try. This canal, yes, I have prepared that canal using the Colton. Now my topics, that is the Wave 1 file. It is very simple, very simple. And it has already 3 files. If we divided the canals into the 3 groups, that is small canal, medium, and the large canal, then one file is, that is you are observing 3 files here. One file is for the small canal, another file is for the medium canal, and another instrument is for the large canal. Actually, 3 factors is related for successful endodontics. Shaping is very important. At the same time, irrigation. Without irrigation, you cannot clean the root canal properly. Proper irrigation, you must have. Here our friend is sitting here, he is introduced a new device for irrigation, properly cleaning of the root canal system, yes. Yet I am not using this one, I will try in future, unit instrument also. And ultimately, you get the 3-dimensional observation. That is single file. This single file technique, that is a time saving. You can decrease the global time. We have no time. If you want to prepare the root canal with say, single file technique, that is wave one technique, only 10-15 minutes is required for prepare of the canal. Only 10 minutes is sufficient for preparation. আমরা যদি ইচ্ছাও করি তাহলেও কিন্তু আমরা দ্বিতীয় ভ্যারিয়েন্ট ইউজ করতে পারবো না। আমি ওদের সামনে ওটা ইংলিশ বললাম না আমি, কারণ আমরা সব চেষ্টা করি যে এটা বারবার ইউজ করা যায় কিনা, কিন্তু দিস ইজ ইউ নো আমরা ট্রাই করলে যদি ট্রাই করি যে আমরা আবার ইউজ করব, তারা ডিজাইন করছে এমনভাবে ডিজাইন করা হয়েছে যদি তুমি স্টেরিলাইজেশন দাও তাহলে কি হবে, এটার হ্যান্ডেলটা ডিস্টর্টেড হয়ে যাবে।